So we were reviewing ventilator-assisted pneumonia. So our nursing role here, let's go ahead and look at these notes here. We're going to look at a couple care bundles in a second. But our things that we do as nurses, our biggest thing that we can do is proper hand washing, okay? And the second thing is oral hygiene. And that we address by suctioning with a closed system. So you'll usually see this plastic thing. This is a suction tube, and it's out of the body right now, or out of the tube, and then the nurse is preparing to go ahead and stick that down in the tube. And here, it's just, this is where it's attached to the ventilator itself. But this is the suction catheter, and so this is what we mean by keeping a closed system to help prevent secretion, pooling, and then good hand hygiene, or good mouth hygiene, oral hygiene, keeping the mouth membranes free, clean and free of secretions and buildup. So that involves cleaning it with oral swabs. And then we want to prevent aspiration of gastric contents, which can also help prevent VAP. And we do that, the patient will normally have an NG tube, or will be on some kind of PPI, so like pantoprazole. Sorry about that. Okay, so this is an example of a care bundle. There's some over here, and then there is another example over here. The other thing that I want to go over, so sorry, just make sure you know that about the nurse's role and management of ventilators. Down here, nursing monitoring. So things that we'll do, that nasogastric tube to prevent, NG tube to prevent aspiration of gastric contents, administering pantoprazole. We measure the ET tube length. Usually it's measured at the lip or at the teeth. So I'll have to check and see what your agency policy is on that. In order to prevent skin breakdown in the mouth, we'll move the ET tube to the other side of the mouth daily. The patient will be sedated. Patients won't be awake. We will turn up the FiO2 and pre-oxygenate prior to sterile suctioning to help prevent respiratory distress. Because the patient, if we look at that picture up here, when we're suctioning, the patient's not going to be getting any airflow because we're down here in the tube. So just like when you do a tracheostomy care, you pre-suction the patient, or prior to pre-suctioning the patient, when you're suctioning a trach, you pre-oxygenate the patient. Sorry, I'm back up here on slide 54. Okay. And then we'll keep track of the patient's level of consciousness. We do want them to be sedated, and then we'll do those measures to prevent ventilator-assisted pneumonia. And you want to check, this is really important. This whole list is really important. Make it great multiple response question, you know. Check the vent settings. We do not check those daily. You actually check them every 8 hours. Okay, so not just once daily or with your shift, but every 8 hours. That's something to keep in mind. Okay, the other thing that is very important to know, we're going to talk about troubleshooting. And I think one of the most annoying things that people encounter or fear with ventilators is the alarms. Okay, so we're going to take a very practical approach to this, okay? So if you have a low pressure alarm, that means that you're losing air somewhere, okay? So if we've got low pressure, that means leak, like a low tire, like low air on a tire. This means that there's a disconnection or a leak somewhere. So the other thing that can cause this can be the ET tube cup can be deflated and may need to be reinflated. But all of those are examples of we're losing air somewhere. If you get a high pressure alarm, this means that pressure's building up because there's some kind of obstruction. So I always think of the cartoons where there's a, the hose is plugged or a tube, and then it's inflating until it blows up in the cartoon character's face. So if we have something like that, then there's some kind of obstruction happening. That it's some kind of kink. Either it's caught on the equipment, it's kinked in a bed railing, the patient's biting the tube. We need to check the peak airway pressure gauge and check our patient. So you check all of these. Perhaps the patient is biting. It could be because they need suctioning, or they have anxiety and they need a little bit of calming, or they need medication. And then the other reason is because there might be a possible change in lung compliance due to mucus, but it could be the development of a pneumo or heart failure or pneumonia. So if you're encountering a high pressure alarm, the first thing to do is to check your patient, okay? Just start at the mouth and go down and look at all the tubing. If you've determined that the tubing is completely unkinked, but you're still having a high pressure alarm, then next go ahead and look at the alarm itself and check the peak airway pressure gauge. If that is set where it's supposed to be, then go back to your patient and check the patient. Are they biting the tube? Do they seem anxious? Go ahead and suction them. And if you've done all these things and you're still having a problem, then we need to suspect something else, like a pneumo, heart failure, or pneumonia, and then we just would ask the physician for a chest x-ray, and that's going to tell us if we have any of those problems. I really like this guide. I stole it from someone else. But the biggest thing I want to make sure that you do is never turn off that alarm, okay? And then check, depending on what kind of pressure alarm you are, check for that issue. So remember, low pressure means air leak. Air is leaking from somewhere. High pressure means there's some kind of kink or obstruction, and that's what you need to look for. The last thing we're going to go over is chest tubes. We've already had an introduction to chest tubes back when we were doing skills, but we're going to go over a couple things again to remind you. So remember that a chest tube is going to be inserted in between the pleural lining and the lining of the lungs when there is any kind of collection of fluid or air in the pleural space. And that's because the patient is probably in respiratory distress because they don't have lung tissue for gas exchange to be happening. So in order to get that lung to re-expand, we need to remove that air, remove the fluid. I do, just of note for your own edification, knowledge base, know that the actual chest tube that goes into the patient's chest can vary in size. The interventional radiologist I assist, if it's just for air and we're not expecting any fluid out or any blood clots, we'll just go ahead and we'll put in a very small tube because we want to cause as little harm to the patient as possible. Smallest risk for an air leak, the smaller the tube, and less discomfort for the patient because this is going in between the intercostal spaces. It is very painful, I should say. However, if the patient has experienced some kind of trauma or they need, we're expecting a lot of blood clots, or maybe they just had a lobectomy in which they had a lobe of their lung removed, and they're having a lot of drainage and blood, we might need a nice big 32 French. And your reference point for that, you can think about a Foley catheter. A Foley catheter, we usually put in 14 or 16 Frenches. So really big at 32. So what's our role, the nurse's role? We're well not necessarily going to be putting in the system itself, but we've got a couple other jobs to do, and I do have that on a different slide. But before we go over that, let's review our chest tubes. things. This is really important. There's going to be a couple questions about chest tubes on your exam, so please pay attention and get to these things, okay? So there are two different kinds of chest tube systems, and it's based on their suction. So you can have we usually call it a water seal, but it's a water suction or a dry suction, okay? Either there's one of the two, and there's this one over here on the right with these little bears. This looks like a pediatric one, as well as this one over here on the right. These are both water suction systems. How can I tell them apart? Well, we have to look at the individual components. First of all, we have these three chambers here in which fluid, as we start sucking it out of the body, fluid or blood, it fills up this chamber, and it has to fill this chamber all the way up, and then it starts spilling over into this chamber, and then that one fills up and it spills over into this. So you can see this holds 2,000 milliliters of fluid or blood, whatever's coming out of the patient here. Okay, and both of them have those characteristics. The second thing that we both have in both of these is a water seal chamber. What that is it creates a one-way valve so that air can escape from the patient, but no air is going to be sucked back into that pleural space, causing negative pressure and collapse of the lungs. We want to get that air out. So we have this water seal chamber. Very important to remember about your water seal chamber, okay? Very, very important. We put 2 centimeters of water in it. Now, how do I know that I have 2 centimeters? Well, 1, there's a little tick mark, and 2, it's sterile water, and it comes on the back of the chest tube. So you can just, as you're opening this system, you'll note that there's a little tiny plastic squeezy bottle of water in the back, and that's how you fill that up. And then if we're setting up, the next thing that we want to look at is our suction control. So far, both of these have the same characteristics, except for our suction control here. The dry suction has this orange thing on it, okay, here. And that's where you set it. You can set it to negative 20 centimeters of suction, negative 30, or negative 40, depending on the nature of what we're trying to fix. On lung compliance, we may up it higher, or if we're talking about an elderly patient, we may have it lower on negative 10 centimeters of suction. For these water seal, these are set to 20 negative centimeters of suction, and how we accomplish that is by putting water in here. Now, we're looking at 2 different things for water. There's going to be a lot of questions about your water seal, okay? And your suction control. So know the difference. In your water seal chamber, when a patient inhales, you can expect that when the patient is going and inhaling and then exhaling, the water in here is going to go up and down like the waves of the ocean, and that is called tidling. This going in and out, like up and down like the waves of an ocean or the waves on the beach. They go up and down, tidling, okay? There may occasionally be gentle bubbling in here as air comes out, especially with the pneumothorax, but remember it's occasional bubbling. Now, with the suction control chamber, we attach, this tube goes into the wall suction unit, and we want to have continuous bubbling over here. If you have continuous bubbling in your water seal chamber, that means you have an air leak. Air leak is bad. We don't want air leaks. So we should expect to see tidling. Now the tidling, once we're done, once we have resolved the pneumo or the hemothorax, we can expect this tidling to stop. Okay? And then if we have a decrease in water in here, then we're going to have less suction. But just know that we do want continuous bubbling here. We do not want continuous bubbling here. There's a video for you. And then this is our nursing management, okay? Another great multiple response question. Last up is some troubleshooting. There's a thing to read down here for you about troubleshooting. And here's another video for you. Someone else explaining it in a less squeaky and probably more interesting voice, because I don't have one right now. So that's chest tubes. Everything's done. Good luck.